Hey Super Mamas, it's Dr. Joy here and you're watching Delivering Joy MD TV. Welcome to Super Mama Sunday, where we have been talking about birth emergencies. In this playlist, all the videos are about birth emergencies. And I want to say as a disclaimer that this is not meant to promote fear of the birthing space, but it is meant to promote awareness. I think it's vitally important that when these rare OB emergencies occur, that the OB care team and the mama and support people know how to respond. So I hope that you're going to watch this with a labor and birth support person of yours. Today's video is going to be dealing with shoulder dystocia. So make sure you keep watching to get these important details. All right, Super Mamas. So as I said, birth emergencies are quite rare, but when they do happen, it's vitally important that you are prepared and at least have some idea about what's going on and what should be going on. So shoulder dystocia is really a fancy medical term for baby's shoulder is stuck. So once the mama has birthed her baby's head, the shoulder actually gets stuck under her pubic bone and holds the rest of the body from delivering. So this is an emergency because we need to recognize it quickly and help that mom birth her baby safely. Shoulder dystocia occurs in up to 3% of births, and this has been on the rise lately. Most literature quotes a 0.2% up to a 3% chance of shoulder dystocia. And there are certainly some risk factors that we'll get into, but we know that this incidence has been increasing. So we're seeing more shoulder dystocias, and probably due to the fact that more women have obesity prior to becoming pregnant and more women are gaining excessive amounts of weight during their pregnancy. In addition, because of diet and lifestyle, some of us may be at higher risk of gestational diabetes. That can certainly lead to an increased incidence of shoulder dystocia. So shoulder dystocia is important to recognize quickly and to act quickly so that that mom can birth the remainder of her baby's body as soon as possible, because when the head has already been birthed and the rest of the body is still inside the birth canal and the uterus, we may not be getting appropriate oxygen to that baby. So very important that both OB care team and mom and supporters are all working and focused on that one goal, which is helping that mom safely birth her baby's body. The important thing that everyone should know is that a shoulder dystocia can happen in any birth, even in a C-section. While we don't expect shoulder dystocia to happen more than 95% of the time, in those rare instances when it does happen, we've all got to be prepared and focused on trying to alleviate the dystocia. In terms of risk factors, certainly having obesity prior to becoming pregnant or a body mass index over 30 can be a risk factor. And yes, I know that the body mass index is not really the best measure, but it is what we have and what we use as a working diagnosis. So a body mass index of over 30 constitutes obesity, but doesn't really necessarily bring into play other factors, like if you're very muscular or you're very tall or the density of your bones. So don't throw smoke at me. I get it. The BMI is not the best indicator, but it is what we're using in terms of research and determining the evidence. Excessive weight gain during pregnancy can be a risk factor for sure. So based on what your weight was pre-pregnancy, you want to plan to gain the appropriate amount of weight. And if you haven't seen my video that I've linked up here on eating for two, definitely a must-see, because it can help you understand what amount of weight you should be gaining. If your body mass index is above 30, 11 to 20 pounds is what you want to gain for the entire pregnancy. So don't let people tell you that you're eating for two. You're really eating for one with some nutritional enhancements. Gestational diabetes is another risk factor. So gestational diabetes is where a mama develops diabetes during her pregnancy. And we know that this is due to the hormones that the placenta is making, and that makes it more difficult for you to absorb the sugar out of your blood. So gestational diabetes can also happen to any mama. And if it does happen, it's very important for those blood sugars to be controlled, because what happens is that excess sugar can cross the placenta and cause the baby to make more insulin, which is a growth hormone. And so these babies get big and bulky, and especially around the shoulders. So that is why gestational diabetes can be a risk factor for the shoulders getting stuck. So if you're gestational diabetic, make sure you're checking your blood sugars, make sure you're following your diabetic diet, and that you are discussing with your OB care team a plan for how you're gonna be managing this, because well-controlled gestational diabetes can certainly decrease your risk of having shoulder dystocia. Fetal macrosomia is another really big term that just means big baby. So women who may have gained excessive amount of weight or who just are genetically larger may grow larger babies. Normally our body grows the right baby for our size. However, there are some folks maybe who have genetic predisposition to be larger, just like you have bigger people and smaller people. If your baby is measuring large, this is something that can certainly predispose to shoulder dystocia, although any size baby could have a shoulder dystocia. I get a lot of questions from mamas about, oh, my estimated fetal weight says the baby's like 9 pounds. Well, estimated fetal weights from ultrasound can vary by up to 20% and sometimes more. And the further along you get into the pregnancy, the less accurate it really is, especially as you get out into 39, 40, 41 weeks. The ultrasound is going to tend to overestimate, but it is important to know if we're expecting a larger baby, both for the mama and the OB care team, so that we're prepared. And honestly, if you really look at the evidence surrounding this, the best judge of estimated fetal weight is the mama, so you are. And we can do fetal ultrasound, we can do Leopold's maneuvers, which is where your OB care provider may like manipulate the stomach, and basically, scientifically, we're comparing the size of your baby to a 5-pound bag of sugar. I was just so flipped out when I heard, because I thought this was like some kind of real scientific technique. Nah, girl, we are really comparing how we think your baby feels compared to a 5-pound bag of sugar. So honestly, mamas are usually the best judge of having a big baby, and they kind of know because they're carrying the weight around all day. Another risk factor for shoulder dystocia is having had a shoulder dystocia in the past. So if you've had a shoulder dystocia in the past, that's something you certainly want to let your OB care provider know. Or if someone told you your baby got stuck in the birth canal, that's something to talk to your OB care provider about. So now that we know the risk factors, we can easily think about prevention measures, right? So gaining the appropriate amount of weight. If you have gestational diabetes during your pregnancy, making sure that your blood sugars are well controlled, that you're eating a healthy diabetic diet, exercising at least 2.5 hours per week, and just really taking care of yourselves and being thoughtful about the choices that you're making about your health and the health of your baby. In addition, your OB care team should pay attention if we know that you are a gestational diabetic, or we think that you may have a really large baby, paying attention to whether or not that baby's head is descending well into the pelvis during your labor. And that is something that is kind of like an art and a skill. And usually mamas are a very good judge of when that head is getting close to the exit. So with shoulder dystocia, this is a condition where the head may actually be delivered by the mom easily, but then the shoulder is stuck. So important to follow that. If you are someone who's been in labor for a really long time, maybe you've been 8 or 9 or 10 centimeters for hours and hours, or maybe you've been pushing for hours and nothing seems to be happening, or people start talking about operative vaginal delivery like forceps or vacuums. These are all things that we should be keeping in mind when we're thinking about a shoulder dystocia occurring. These are just some warning signs that there could potentially be a shoulder dystocia. And while it may not happen, as a matter of fact, most of the time it won't happen, we all need to be thinking about that and preparing in our minds and running through the different maneuvers that we're going to talk about. So I wanted this video to be useful for a wide range of folks. So I'm going to go down a couple of acronyms that you can use and that OB care providers can use. And I hope our OB care teams know this, but sometimes you need a reminder because these are really rare conditions. So I'm going to go down the HELPER acronym for any healthcare providers, and I'm going to go down the B.E.E. C.A.L.M acronym for my mamas and their support people. I guess the first thing we need to do is actually recognize that there is a shoulder dystocia. So turtle sign is a term that we use in the OB care community to talk about the baby's head sort of looks like it's about to deliver, and then it kind of comes back into the shell, and then it looks like it's about to deliver, and it comes back into the shell. And so when that happens, then you should certainly be prepared for a shoulder dystocia. Turtle sign can sometimes be a little difficult to recognize if there's a lot going on in the birthing space, but it is a telltale sign that a shoulder dystocia may be about to occur. So let's say we see turtle sign, you deliver your baby's head, and then the shoulder doesn't come. What are we gonna do? We're gonna help her. So helper is an acronym that we use in the OB care community to remind us about what we're supposed to be doing. So it's HELPERR. So H stands for help. Call for help. If there's not a lot of folks in the birthing space and you need some additional hands to help out, we should either hit your nurse call button or someone stick their head into the hallway and say, we need some help, because you're gonna need enough people to make sure that we're able to help this mama birth her baby safely. E is evaluate. And let me say that again, evaluate whether or not an episiotomy could help. And an episiotomy is a surgical incision that's made in the vagina by the OB care provider. And that in this situation would be to help give more space to allow the OB care provider to get fingers or a hand into the birth canal to try to turn the baby or maneuver the baby in a way such that the anterior shoulder can get underneath that bone and the rest of the baby's body can be birthed. Now, I said the key word was evaluate here because I very rarely need to cut an episiotomy. As a matter of fact, I can't even remember the last time I did cut an episiotomy for a shoulder dystocia. So the first thing that you need to do is just evaluate. Can you get your fingers? Can you get, your hand in that birth canal to be able to have access to that baby's arms and shoulders? If so, there is absolutely no need for an episiotomy. And for me, I have these, long, kind of skinny, moderately skinny fingers. And so it's very easy for me to perform the maneuvers to help get a baby in position so that mom can birth the rest of the baby's body. As for legs, want to get those legs flexed back into the chest. If mama is delivering on her back, then we want to flex the knees back to her chest that way. If she's delivering in another birthing position, it's also totally okay if she's squatting. We want to just get those knees into the chest. That opens up the diameter of the pelvis. So knees to chest, that's what we call McRoberts positioning. And it can be done from your back, or if you're on all fours, or in squatting position, but just knees to the chest. Think I need to get my legs in as close to my body as possible. P is for pressure. Suprapubic pressure, meaning that we're taking a fist and actually putting it right above that pubic bone and trying to dislodge that anterior shoulder, kind of trying to help pop it out from under that bone so that mama can birth the rest of the baby. And E is for enter maneuvers. So it's time to start some maneuvers if your McRoberts positioning with the legs in as close to the chest as possible is not working, or if suprapubic pressure is not working, the maneuvers are next. And there are several maneuvers that are out there. One of the things that I like to do personally is to try to release the posterior arm. So the bottom part of the vagina, called the perineum, is actually the most stretchy, elastic part of the vagina. So I can get my fingers in underneath there and sweep the baby's posterior arm out, then the anterior shoulder will usually easily deliver. If that's not working, by releasing the posterior arm, which would be the R in helper, then I go to the other maneuvers. So I will try to do a spin move where I can either put the fingers up against the anterior shoulder and spin clockwise or counterclockwise, or putting the fingers by the posterior shoulder and spinning clockwise or or a counterclockwise. You can also try to do both at once, putting your left hand by the anterior shoulder and your right hand by the posterior shoulder, and basically kind of trying to turn in a counterclockwise movement to see if you can release the shoulder from underneath the pubic bone. And very, very rare, almost never happens, is that the only thing you may be able to do is try to see if you can push the fetal head back into the birth canal and proceed for an emergency section. But that is completely rare. And so I've never actually had to do that. And I don't really know too many OBs that have ever had to do that. So we discussed that the first R was remove posterior arm, which I already went over. And then the second R is to roll onto all fours. Now, most mamas these days use an epidural for their birth, and so it can be really difficult for them to reposition their entire body because maybe their legs are really numb or heavy and they're not able to move them well. But we can certainly help to turn mom, and this is a great place for supporters to jump in and help out, is to help us turn mom if she's not able to turn herself over onto all fours. So kind of like a cat-cow pose almost. And again, we want to get those knees in close to the chest to open up the diameter of the pelvis so that mom can birth the rest of her baby. So helper. Helper is the acronym for the OB care team. And I think it's important that mamas kind of have an idea about the maneuvers that this care team is going through, because if you don't know, you can't be helpful, right? So for mamas and support people, I want to focus on the acronym B.E.E. C.A.L.M. And that's exactly what you and everyone else in the room needs to do if one of these OB emergencies happen during a birth, is that we all need to be calm, take a deep breath, and then think about what needs to happen and in what order. Set some priorities. And mamas, do not push. If you can avoid pushing during the shoulder dystocia until we've been able to do some maneuvers to get baby in a better position for you to birth it, it's much better if you don't push, because the more you push, the tighter you smash that shoulder against the pubic bone. If you are laboring without an epidural and you're birthing your baby naturally, it can be really difficult not to push when the baby's head is sitting right there at the vagina. But if you can avoid it, or if you can avoid pushing with full strength, that will really help maneuver through getting the baby in a better birthing position. E is for elevate legs. Get those knees into the chest, whether you're birthing in a squatting position, on your back, or on all fours. Getting into a position where the knees are in close to the chest is very helpful. C is call your support. So if this is happening to you, you want your support people close to you, because you may need their help to get onto all fours, or you may just need their support and their nearness so that you can stay calm. But call your support to you if you've got supporters in the room. I know right now during COVID-19, it's been really difficult for us to have supporters, but often, during birthing under normal circumstances in a hospital, you're gonna have several people around. And certainly if you're birthing in a birth facility or at home, you should have some folks around to help. So call your support. A is ask questions. Ask questions, because if we are so caught up in doing our helper acronym, we may forget to talk to you. So talk to us and say, hey, is everything okay? Is something going on? Are you concerned? Because we need to be talking to you so that you understand what's going on. And it really doesn't waste time to do that, but we need to be able to say, okay, hey mama, your baby's shoulder is stuck. We need to try to reposition the baby, and then we'll ask you to push with all your might. So we need to be talking to you. So if you know that something's happening, ask questions about it so that you know what's going on, so that you can be involved in facilitating a safe birth for your baby. And support folks, it's okay for you to ask questions too. L is for listen. Once we are able to reposition you and reposition baby, we will be coaching you on when to push. So pay attention to those instructions as closely as you can in the moment. And M means make sense to me. Make sense. So After everything is done, once we've safely helped you birth your baby, it's important for us to go over what took place in the birth. So, I'm a big debrief person. Like, we need to run it back, see what happened. Were there any risk factors that you had? Were we prepared? What was the outcome of the birth? Were there any birth injuries? Birth injuries can certainly occur with a shoulder dystocia because there's a large bundle of nerves here in the neck called the brachial plexus. With the brachial plexus being stretched by that shoulder stuck behind the bone, you can certainly get injuries that can be temporary or permanent. In addition, sometimes the only way to safely help mama birth her baby is to break the clavicle or break the humerus bone to get that shoulder to collapse in and slide under that bone. So if that happened, we certainly need to be talking about that, getting x-rays, making sure that everything is going to be okay for that baby. And most times those babies are just going to end up in an arm sling for a little while, and then they're going to be completely normal. So it's important to run back what happened, what the outcomes were. If mom has any feelings or concerns about what happened, we need to talk about that. If you have questions about what happened, we need to talk about that as well. And you need to understand that you had a shoulder dystocia. So all of this should make sense for you before you go home from the hospital. So once everything's calm and quiet, we need to sit down and have an extensive conversation about what happened and what you need to know about birthing in the future. Because as we said, having one shoulder dystocia can increase your risk for having another shoulder dystocia. So I hope today's video has been helpful for you and kind of just giving you some ideas and ways to think about this particular birth emergency. Please be sure to drop your questions and comments below. If you want to learn more about the maneuvers or things that we do in shoulder dystocia, if you're a healthcare worker or you just have questions about them, I'll be happy to provide some information on those. And if you have had a shoulder dystocia, definitely would love to hear your story in the comments. Make sure that you subscribe so that you don't miss a single Super Mama Sunday episode, and that you share this information with someone who could use it. All right, Super Mamas, I'll catch you next week. Peace.